Good afternoon, everyone. Welcome. Welcome to the third session of the webinar, Thriving in Substance Use Disorder, Service Delivery in the Post-COVID Era. My name is Andrea Havler, and I will be facilitating these sessions. First off, thank you to all of you for being here. It's very nice to see the receptivity, the reception, the interest that you all have shown in this series. So before we start, I want to remind all of you that this session is being recorded for later distribution. However, the information that you see on the Q&A box will not appear on the recordings. And please feel free to use this Q&A box to add all your questions. Our speaker will get to those later on as she finishes her presentation. We want to remind you also that this 8-part webinar has been created by the Center for Substance Use Training and Telementoring CSTAT in collaboration with the Texas Health, Human and Services Commission with the intention of training our behavioral health professionals on how to manage and mitigate COVID-19 as it relates to substance use disorders. So this is our third session, and we're very happy to see all of you here. Again, that Q&A box, we would like you to use it to add your questions, and we will get there at the end of the session. Today, as always, we'll be distributing 2 types of credits. We are going to be giving CMEs, and for that, we will be sharing with you a text code after the presentation. Please try to text that code today before midnight to make sure that you receive your CMEs. And for the Cs, and with that I'm referring to the certificates for behavioral health professionals, those will be sent to you after this class. You would have to complete our possession survey, and you can give it somewhere between 2 and 3 weeks for you to receive the certificates. Again, thank you. And without any further delay, we're going to start introducing our presenter of the day, Dr. Monica Verduzco. She is an accomplished psychiatrist, and she is the chair of the Department of Rehabilitation Medicine here at UT Health San Antonio. Dr. Verduzco, thank you again for taking the time to present for us. Whenever you're ready, you can introduce yourself and start with your presentation.
Yes, thank you for having me today.
You're welcome.
Start sharing this, and there you go. And I am a physiatrist, not a psychiatrist. So a physiatrist is a specialist in physical medicine and rehabilitation, which also is I'm an MD and had that specialty in PM&R and in brain injury medicine, and now specialize in long COVID. And so this is really an untapped topic that we're coming into today, but something that's very, very important. So I'm really thankful that I was invited by Be Well Texas to be part of this learning series and to have you here learning with each other today. And I'm really excited more probably about the end and kind of taking your questions and seeing what are the next steps in this area, because I really feel there's still so much that's so untapped when it comes to this intersection of substance use disorder and long COVID and what we've seen and what we're not seeing. So today we're going to talk about this intersection of long COVID and substance use disorder. And then also, what are the impacts of treatment for both of these things and for recovery? We're going to talk a lot about stigma. Stigma is something that you're going to start hearing in these slides about what happens with persons who have long COVID, and then compounded by substance use disorders, who is another group that has stigma as well. And we're going to talk a little bit about integrative and multidisciplinary approaches for managing both of these things. So I will start first with talking about terminology. So what are some of the words that you might hear that I might be talking about? So what is long COVID? And so this is going to be long COVID, the disease state, a chronic disease state. I think, there's different definitions, but probably around 3 months of symptoms or more after someone has had initial infection with COVID-19, and sometimes the symptoms continue. Sometimes the person gets better and then they have new symptoms that arise. Sometimes someone might have an underlying disease that then becomes a lot worse afterwards. And so this kind of all embodies long COVID. So it's either symptoms, syndromes that occur and that are kind of triggered by a COVID infection. Long hauler, that's usually someone that is a COVID-19 survivor who has these residual effects. That was a term that, is a patient derived term. I usually don't use the word long hauler. I'd like to use patient first language. So I might just say like person with long COVID. The other thing that you might help hear used also is PASC, post-acute sequela of SARS-CoV-2 infection. This is the NIH term that they use, and kind of it's pretty much the same as long COVID. Those are both going to be used in tandem, and sometimes you might just read about it in other places, like post-COVID condition, PACS, etc. So here it'll probably be mostly I'm using long COVID, or you might see PASC in some of the slides kind of being the same thing. So concepts to know, things that, what are some of the take-home messages that I think first, that long COVID is a clinical diagnosis. So always we want like, okay, what's the biomarker? What's the blood test? What's the abnormal result? And, right now what we have is clinical, and listening to patient stories and seeing, do they have a history of an infection or a presumed infection? Do they have a new, disease state or symptoms related afterwards? And so it's very much a clinical diagnosis at this time. Patients need to be heard and listened to, and their stories need to be heard, and that's, and it can happen to anyone. And the other thing is every new COVID infection or reinfection is going to increase the risk of long COVID. So even though you've said, I got COVID once and it was fine, but actually they're saying like the more infections you get, some of those reinfections can increase your risk of getting long COVID, of having hospitalizations, of it actually also increase risk of death too. And so still important not to get COVID and COVID over and over and over again. Long COVID's a public health emergency. There are probably, I think if you look at the household pulse survey data right now, about 6% of all US adults are reporting having long COVID, and it impacts a lot of people significantly and it keeps them out of work. And so because of that, this is a public health emergency that needs to be addressed, just like we addressed acute COVID. And preventing long COVID's important. And, one of the things is not getting infections, and, vaccinations also decrease the risk of having long COVID, but it still can happen to anyone. So what does recovery from COVID-19 look like actually? And I think that we've seen heterogeneous, like it can be so different for everyone. If someone got it sick at the beginning of the pandemic, is going to look a lot different than people who get sick from COVID now. And still, all along, there's been people who've had like silent disease, asymptomatic COVID, some that were severe, some of this data is from early in the pandemic, 2020, where, 17% of people were dying. And we know the numbers are not like that at all, but still, there's 2,000 people per week in the United States who are dying of COVID. And anywhere the data had been anywhere from 10 to 50% of people developing long COVID. I think if you look at it now, it's probably overall closer to 10% of people who get COVID will get long COVID. And then the other thing is we don't know what's going to happen, down the road long term. Is we've only seen kind of COVID for 4 years now, and we don't know what's going to happen with people who've had COVID decades from now, because we know sometimes some infections put patients at risk for cancer down the line, but we don't find that out for years or decades later. And so this was something that came out of an article recently, again, 10 to 30% of people developing long COVID, adults and children. And it affects so many, almost every like body system that we have can be affected. And that just shows you like our immune system's impacted, endocrine system, brain, heart, endothelial cells, and blood vessels. And as I tell patients, we have blood vessels all over our body. So, long COVID can impact every literally part of our body because our blood vessels go everywhere. And there can be, microclots that affect all these other organ systems. So very still serious thing. So what do we know about this combination of, at the beginning of the pandemic, really, it was like COVID-19 and substance use disorder. At the beginning, there was this intersection of like the pandemic itself, and we already knew we were in an epidemic of substance use disorder. So this has really become like complex and challenging landscape for public health. And the pandemic has exacerbated these existing vulnerabilities within these communities. And so there's been, we knew there was increased rates of addiction, of relapse, of overdose, especially at the beginning parts of the pandemic. And so we have to address this intersection, or it's been, addressed for the last 4 years. And that's going to be public health interventions, mental health support, community outreach, policy reforms, and making sure there's equitable access to care because of the devastating impact individuals and families have. And so really these two pandemics with epidemic created quite a collision course at the beginning and during the pandemic. And so what was seen early in the pandemic was kind of the epidemic was worsening from substance use disorders, and there was lockdowns, there was social distancing measures, there was economic instability, and that really isolated individuals from their support systems. They were not getting the usual supports they were getting, especially, as clinics closed down and such, and they were not getting peer groups, they were not getting counseling services, maybe even hard to get to their treatment facilities. And so this amplified feelings of loneliness and despair. There was disruption to drug supplies, disruptions to the drug supply chain. And there was proliferation of dangerous substances with unpredictable purity levels. And so this was increasing overdose deaths. And then again, the healthcare system is at baseline strained, and that was even more strained during COVID times. And this is going to also limit access to addiction treatment and harm reduction services. And this is all worsening the crisis that occurs just with having the pandemic. So next thing is, what is the risk of COVID-19 on persons with substance use disorder? So what happened to patients with substance use disorder in getting COVID, period? So there was a study from 2021, and they looked at electronic health records data. And this was like more than 73 million patients at 360 US hospitals. And they were found about maybe 10% of the study sample were persons who had substance use disorders. And even though they were just 10% of the study sample, they accounted for 15% of the patients who were diagnosed with COVID. And so they were, more than 1.5 times more likely to have COVID than those without a diagnosis. And also, these patients with these diagnoses were also more likely to have severe outcomes of COVID-19 than those without. So, there was also showing that these patients had more hospitalizations. When you looked at it, it was like 41% versus 30%, as well as death. They had higher, if you had substance use disorder, it was like 9.6% death. Again, this was at the beginning, 2020 of the pandemic, versus 6.6% of death. And so you can look and say like which ones exactly, which type of substance use disorder were the ones at the higher risks. And so subtypes, it was individuals who had opioid use disorder had the largest risk, followed by tobacco use disorder. If you think like tobacco impacts, lungs at baseline, probably already having that kind of comorbidity of having poor lung function. And then alcohol use disorder, cocaine use disorder, and then the lowest being cannabis use disorder. So big impacts. And then, as I said, the risk of severe COVID was higher. If they had a lifetime substance use disorder diagnosis, they had these more severe outcomes that I had already talked about, more hospitalizations, more death. And then we saw racial disparities too. So African Americans who had substance use disorder and COVID, 13% died. So that was even higher than just someone who had substance use disorder, versus Caucasians with substance use disorder was 8.6%. So, maybe we can talk about later why we thought this happened. I think we know that racial and ethnic minoritized groups we saw throughout the whole COVID pandemic had worse outcomes, but we continue to see it even in substance use disorder and specifically in COVID and severe COVID. And, some of the other thoughts of like, okay, well, why, like I said, why is this happening? And, one of the thoughts, okay, opioid use disorder was the highest. Is that already something that compromises respiration? If they have slower breathing, then that's more likely to cause low oxygen levels and hypoxemia. And then behaviors associated with certain opioid use disorder or other use disorders are going to raise the risk of contracting infectious diseases of all kind. Also, we're supposed to be social distancing, but people with drug addiction, they sometimes have to have interactions to be able to get the drugs. And so those interactions with people outside their circle, or drug dealers, for example, to get drugs, we're going to increase their risk of getting infection. And then the other thing is lung damage. Like I said, if they have lung damage that's caused by smoking, vaping is also bad for lung health, of course, and in substance use disorder usually impedes access to healthcare. I think this is a little bit what I talked about already, smoking and vaping. If they already had an underlying thing, it's going to worsen it, or if we see a lot of asthma after COVID as well. So it's going to just being someone that smokes, being someone that vapes is going to increase and worsen those conditions. If there's already underlying chronic severe lung disease, or if they have COPD is one of the risk factors for getting long COVID. Of course, if some of those people continue to have tobacco use disorder, then they are going to have more COVID. Sometimes COVID-19 and substance use both affect heart and lung function. So this is going to amplify the negative healths of each thing. High dose opioids, like I said, slows breathing and leads to low oxygen in the blood and having a risk of more severe respiratory infections. And then stimulants. For stimulant, this is going to be methamphetamine, cocaine, amphetamines. These are going to constrict blood vessels, and that's going to increase the risk of heart attacks, strokes, abnormal heart rhythms, seizures. So like I said, COVID's already something that causes inflammation, that causes vascular disease, that causes vasculitis, and underlying use with drugs is going to make it more severe outcomes. This is talking about risk factors of long COVID. So in general, who is going to be at risk for long COVID? And this was a big systematic review and a meta-analysis that came. This was published in 2023, so probably a lot of the data was through all of 2022, where they look at Medline and EM-based databases, and they said, what are the risk factors for a post-COVID condition? And that was going to be the patient's age, so mid to older age. I still think like a lot of my long COVID clinic is kind of this, it's a bell curve, so 40s to 50s is probably the most common age I see. Female sex, so even though males got more severe COVID, I think we're knowing that there's more endocrinological changes that are impacting that women get more long COVID, having a higher BMI, smoking. Okay, so automatically there's already a substance use disorder right there that puts someone at risk of getting long COVID. Pre-existing comorbidities, so that was specifically anxiety and depression. We know that, mood disorders can overlap a lot with substance use disorders, asthma, chronic kidney disease, COPD, diabetes, being immunosuppressed, and ischemic heart disease. So those all also make risk for long COVIDs. And then being hospitalized for COVID also is at a risk for long COVID. And so there is one thing that they found was protective, and that was vaccination. And so patients who had been vaccinated against COVID-19 with 2 doses had, significantly less difference of getting long COVID. So those are some, saying, okay, who are the people that are at risk, and how does that group we see kind of overlap sometimes with our patients who have substance use disorders. So other considerations, there's not tons of research, but we have to remember, things that we're hearing as I'm discussing this. People with substance use disorders were also less likely to be vaccinated. So if you looked at that data, that was seen, again, this group may have less access to healthcare. They may have less trust in the healthcare system. They may kind of listen to some more of the, not true news saying that vaccines were something bad. So they were less, already highly at risk, and on top of that, less likely to be vaccinated. They're also less likely often to see healthcare providers or to have good, established primary care and healthcare. They were having more severe COVID outcomes. That's what we talked about already. We saw that more hospitalizations, more death. There's very little research on this topic. There is a large personal and societal cost with this. So, there's a lot of considerations just looking at the population and their risk of long COVID. So what is the pathogenesis of PASC, or of long COVID? So what is underlying? Why are some people developing long COVID? What's happening at a pathobiological level? And this is something that I think that we're all still trying to understand. These are probably some of the leading theories. And definitely one of the leading theories is going to be immune dysregulation. And so with immune dysregulation, there is some thought that there is a viral antigen persistence. So that means that, yes, you had COVID, you had SARS-CoV-2, and maybe your test is negative, but they find that there's pieces of the antigen, pieces of the SARS-CoV virus, maybe not still alive and active, that is in the body that is driving the immune system. And so they've found that the complement system's been off. They've seen like exhausted T cells. They have seen this immune dysregulation in your body. If your body consistently thinks it's fighting something, then your immune system is going to be going off all the time. And with the immune system going off all the time, that's also like just physically fatiguing as well. And so they've found that, these pieces of virus in the brain, they've found them in the GI tract. There's a good amount in the GI tract also. They found them in fat. They found them kind of all over people's bodies. So a lot of us probably still have some kind of remnants. People with long COVID, their immune system is reacting to it. It's probably also why I think it's really important that if patients are at risk, which I do think that substance use disorder patients we know are at risk for more severe infections, that they should, be treated when they have COVID and be considered to get treatments, antivirals like Paxlovid, so that we can make sure that they, that they're getting the virus cut off as much as possible. So again, if they're at high risk, unvaccinated, having risk factors, substance use disorder. I mean, even when you look at risk factors, they consider depression, anxiety a risk factor. And so these patients, again, should be getting Paxlovid when they have acute infection. The other thing with the immune dysregulation is that there is reactivation sometimes of viruses. So again, we have other viruses, sometimes like especially if anyone had mono in the past or Epstein-Barr virus or herpes viruses, these can be reactivated. And this is often the one that, can cause ME/CFS, the chronic fatigue syndrome, also known as myalgic encephalomyelitis. And so that's why some of these patients also present with that. We know that there is dysbiosis in the gut. So SARS-CoV-2 changes our gut microbiome. And when you have a changed gut microbiome, that can lead to other symptoms. So we say like our guts is like a huge part of our immune system. And our gut, I always say now, is our second brain, because we need what happens in the gut to make neurotransmitters and such. So definitely dysbiosis in the gut happens after long COVID. There's also autoimmunity and immune priming. So that means that, whatever is patients are people with long COVID, in some of the cases, their body is reacting to whatever might be there, or their B cells might be making more abnormal antibodies to something that should be normal in their body, and they're just making more abnormal antibodies, and again, presenting like almost like autoimmune disease. The next thing is blood clotting and endothelial abnormalities. So again, this is endothelial dysfunction, and patients, they will, almost anyone that has COVID, when they do their blood, a lot of them will have microclots, but especially people who have long COVID have these hyperactivated platelets and microclots. And some have larger clots, but also we're finding microclots as well. And then there's dysfunctional neurologic signaling. And so one of the big ones is vagus nerve, and our vagus nerve is our longest, nerve in our body. And so this dysfunctional signaling at the brainstem is causing a lot of abnormalities with fatigue, with the autonomic nervous system. So a lot of time on that slide, but I think the pathogenesis is really important. Article that I read recently about central sensitization and long COVID, but there's also articles about central sensitization and opioid use disorder. So that's one way where I found like that these actually both things can overlap. And so, that was one of the persisting symptoms after COVID-19 infection is central sensitization, a missing link. And so central sensitization is going to be dysfunctional your CNS pain modulating pathways, and they're going to have heightened pain perception. And it's not always assessed in opioid use disorder, though it may be, because often pain is what's implicated in development and maintenance and relapse of opioid use disorder. And sometimes chronic opioid uses can produce opioid-induced hyperalgesia. And so central sensitization is an important mechanism underlying complex relationship between opioid use disorder and chronic pain. And so in this online survey that they did in the Journal of Clinical Medicine, it was suggestive for symptoms of central sensitization in post-COVID-19 patients. And so, this was a quote whereby several dysfunctions within the CNS, altered sensory processing in the brain, altered activity in brain orchestrated, nociceptive facilitatory pathways, and poor functioning of endogenous analgesia can lead to an increased responsiveness to a variety of inputs, because some of these patients have a lot of kind of hypersensitive type symptoms. Again, infectious illnesses is going to induce inflammation. It's going to induce immune dysregulation. And patients with COVID-19 have that dysregulated immune response. And so this immune dysfunction is going to, play a role in disease progression, and viral infections can lead to neuroinflammation, activate microglia, activate astrocytes, and then this can be pro-inflammatory cytokines and chemokines in the brain. Again, so in both these things, another overlap. So what is the spectrum of long COVID? And so when I see patients in long COVID clinic and think about diagnosis and treatment, it's almost like I see two groups of patients. There's some that's like patients that I see and I know, they get a CT scan, their CT scan has like interstitial lung disease or pulmonary fibrosis, or they have acute kidney injury, and there's things on labs that I see, myocarditis, whatever it might be. And we know how to kind of treat those. We have traditional interventional approaches and traditional rehab approaches for these things. And then there's the patients that have kind of more syndromic long COVID, where it's like they might have the myalgic encephalomyelitis, chronic fatigue syndrome. They may have dysautonomia or POTS, this autoimmunity, and so those, we don't always have blood tests for those. We don't always have a good test for those. And then if we do traditional approaches, they may not respond the same way in some of the other disease states. So this is kind of how I think of this and how we have to really think out of the box. So what is the numbers for long COVID? And that is kind of still pretty eye-opening when we look at this is from the Household Pulse Survey, and this is ever experienced long COVID as a percentage of all adults in the US. So in the US, it's about 17.6% have ever experienced long COVID, which is pretty high. You can see, and if you look, it's like I said, the bell curve kind of around that 30, 40, 50 years old, females more than males, higher also in the transgender community and the LGBTQ community, higher in mixed rate and the Latin Hispanic community as well. Again, higher in people who had disability to start. So again, this is a pretty like more than 1 in 6 US adults have experienced long COVID. And then this was showing like currently experiencing long COVID from the most recent data from 2024. Again, 6.8% of all US adults are experiencing long COVID right now. So what are the symptoms? So long COVID can have many symptoms and organ systems. I mean, probably more than 200 symptoms if you look at some of the studies that have been done and some of the studies that have been led by people who actually have lived experience with long COVID. Again, you see the bubbles there, and that this is from a meta-analysis, so like fatigue, headache, pain, weight loss, hair loss, sweating, smell, attention disorder, memory loss. I mean, a whole bunch of things across the board. And the Recover is an NIH trial at multiple sites. Here at UT Health San Antonio, we're one of the sites. And there is a study already that has been published in JAMA, and some of us are the co-authors on them. And these were some of the top symptoms in the Recover trial. So smell, taste, post-exertional malaise, chronic cough, brain fog, thirst, palpitations, chest pain, fatigue, sexual desire being impacted, dizziness, GI, abnormal movements, and hair loss. So, these are the kind of things that we hear of in our clinics. The other thing is, this is like a nice table that shows all the past symptoms that patients will have, because some of them will have, they'll feel short of breath, but their x-rays will be fine. They're feel like their heart rate goes up and down, but again, they've been told their EKG is fine and their echo is fine. And so, like I said, there's likely that there's multiple different mechanisms involving these symptoms and multiple pathophysiologies behind these common symptoms. And so this is kind of a graph that depicts how interrelated these symptoms are and how patients need to understand how very disparate symptoms can all be related, but there's not necessarily mean that they're organs are damaged, but it's probably not a primary heart problem or a primary lung problem, but it's more kind of a systemic effect of the immune system and really needs a holistic approach to care. The other thing to look at these and to consider is that in sometimes patients who have substance use disorder, if they're in withdrawal, can look like a lot of these symptoms. And so it's also something that really needs to be considered, like, are they in withdrawal? Are they not in withdrawal? Is it part of just long COVID symptoms? Do we have to consider one thing or the other? So it's something that we have to really be thoughtful about. So what about, how do you diagnose long COVID in someone who has substance use disorder? And I think I had the slides for everyone. I think it's, same for everyone else. We have to listen to their story. We have to listen to, when they had COVID, what was the timeline of events? How long has it been? What symptoms have occurred? Again, lab tests, workup needs to be done, but lab tests don't have to be abnormal. Like I said, some of the top symptoms were abnormal smell, taste, fatigue, brain fog, post-exertional malaise. Those don't have labs, and it's not a diagnosis of exclusion. So one thing that I always recommend is we look for overt organ pathology. So if someone has shortness of breath, I'm not going to say it's just because you smoke, or, oh, it's just because people with long COVID have, shortness of breath. I still will recommend lung imaging and pulmonary function tests. And sometimes we even see, even if they weren't hospitalized, there can still be abnormalities um, on imaging. So again, making sure patients with long COVID, with substance use disorder, get appropriate workup. Same thing, palpitations and chest pain, making sure they get EKGs, making sure it's not a cardiac ischemia, getting an echo, making sure they didn't develop some type of heart failure. And then looking further into autonomic dysfunction or POTS, because we see that very, very significantly. And then if there's a serious neurologic impairment, making sure patients get brain imaging or other testing as needed. So again, access to care, access to treatment, and not downplaying significant symptoms. Next thing to talk about is going to be a big thing is stigma. And one thing with stigma is that, oh, I like this quote that I found, with stigma associated with diseases is as old as diseases in humans. So again, we know that as long as patients have had diseases, as long as people have had diseases that are less understood, that these have been stigmatized. And we see this a lot in substance use disorder, and now we're starting to see it a lot also in long COVID. So stigma, again, is going to be very traumatizing to patients. I've had patients who have said, I know people personally who are, clinicians, and they're like, I'm not going to tell anyone I have long COVID because I don't want that in my chart. I don't want to be stigmatized for it. I mean, there's still some clinicians that don't even believe in long COVID as a thing. And so this was a survey based that came out of the UK and had stigma questions answered, mostly females in their 40s. And the prevalence of experiencing stigma, at least sometimes or often always, was 95% for sometimes and 76% to often or always. And more than 60% were cautious about who they talked to about it. And 34% said that when they did disclose their diagnosis, that they had regretted doing so. And so I even think about, sometimes I've covered on the inpatient service, seeing patients, again, rehabilitation patients, and I've seen notes where other doctors have been like, this patient has, hypertension, diabetes, and long COVID, and they put it in quotes, but they didn't put diabetes in quotes. They didn't put, um, whatever their heart failure is in quotes. So it's like, yes, even in reading a note, I see it being stigmatized. And so these patients are processing a lot of trauma. We know that that substance use disorders, they're chronic, they're treatable medical conditions, but studies also show people with these disorders face discrimination and stigma as well. And this can impact their health, this can impact their well-being in numerous ways. And it also affects people who use drugs who do not have a substance use disorder. I know, these are the things we have. There are safe, effective, life-saving tools available to help people who have substance use disorder, but stigma is sometimes part of the reason why they don't seek care. And the language that people use can contribute to stigma and discrimination against people with substance use disorders, including by healthcare professionals. And sometimes we still see like words and charts that are like addict or substance abuser, these are not, please, yeah, don't use these terms, right? Because these are going to reflect the misconception that drug use and related behaviors are a choice rather than it's a compulsion. And then this blames the person with substance use disorder. And these terms are going to feed negative biases and dehumanize people. And so this language will also sway clinician attitudes. And there's studies where they show like if their clinicians were going to be rating a person described as a substance abuser as more worthy of blame than someone described as having a substance use disorder. So again, I know that it's the same in both populations. So that's why like I put it that like in this patient's a long hauler, and putting it in quotes also can feed into this discrimination and stigma that both groups happen. So what are the impacts of stigma. So patients who need care, they may not seek it. Patients with substance use disorders may face, mistreatment, stereotyping, negative biases, and so they're going to avoid seeking medical help. And so a lot of times, even when they need substance use disorder treatment, they don't seek that care for it. So, even less are they going to seek care for sometimes something else just because of the negative attitude they get from their communities. Um, we know that because of stigma, there's fear of disclosing diagnoses of, substance use. And so they're going to conceal their substance use in medical settings because of their fear of bias or mistreatment. And then they're going to miss important opportunities for care because, like I said, this care needs to be done, and it's done and it's studied and there's treatments. People receive poorer quality of care. And so because of the biases that clinicians can have, they're going to be failed to provide evidence-based care. There's going to be reduced access to healthcare programs, and again, in the end, can be more harmful behaviors. And one thing I will tell you about the impact of stigma, when I have this came out beforehand, it was on Twitter and put out on Twitter. And I was like, okay, I'm going to be talking about implications for long COVID in people with substance use disorder. And the long COVID community came back to me, and there's some backlash of like, are you trying to look at us? Are you trying to say we have substance use disorders? So they are even worried about the stigma that comes with that. And I said, no, I'm taking it from a completely different perspective of, here are two stigmatized groups. Here is a group that has not great access to healthcare, and at high risk of long COVID, and we need to figure out how we're treating and addressing their long COVID as well as their substance use disorder. So what research is there already with the combination specifically of long COVID and substance use disorder? And it's really nothing at this point. This is untapped territory, things that I know that Be Well's wanting to look at when it comes to recover data. But this research, that's this intersection of substance use disorder and long COVID, is going to be crucial for developing effective treatments and treatment strategies. And so here's some like key areas needed for investigation. So epidemiological studies, large scale to look at the prevalence of long COVID, longitudinal studies, so like follow what's happening with long COVID symptoms in individuals who have substance use disorder and what happens over time. We need to look at and investigate the biological mechanisms, kind of like I talked about before. Is there inflammation? Is it, what's happening specifically in this group? Is there a central sensitization? We need clinical trials. So design and implement clinical trials to evaluate the efficacy of treatments for long COVID symptoms, specifically in individuals with substance use disorder, both pharmacological and non-pharmacological. What are the risk factors and predictors? We need to look at the impact of long COVID on health outcomes, and really, again, treatment integration. And then probably what's not there, but of course is important, I've talked about, is like healthcare access and equity, and look at what the barriers to healthcare are for this population. So like I said, a lot of the patients in the long COVID community were worried and like, are you going to look at us and say like, oh, we're using, medicinal cannabis and now we have substance use disorder? And that's a different definition. Like, it doesn't have to be the disordered use of it. But one thing that I did find was pretty interesting, that there are some the study was just a case series. Like I said, there's almost nothing out there. It's like that actually some patients with long COVID or PASC actually have new alcohol sensitivity. And so this is, again, this happened at Stanford's post-acute COVID clinic. And this was only 4 patients, but they found that like the patients reported new changes in their symptoms or behaviors following the use of alcohol. And they were having like headaches, hangover symptoms, worsening of their past symptoms. So, just being really, really sensitive to alcohol. So kind of really interesting that having long COVID just made them feel just horrendous. So what do we have for treatment? So nothing right now is FDA approved for long COVID. This is a link to some guidance, consensus guidance statements that we have for that our society, the American Association of Physical Medicine and Rehabilitation, have made for different symptoms of long COVID. So really we have a lot of symptom management. You know, if patients have headache and migraines, we know how to treat those, trying to treat pain, POTS, cognitive issues, attention deficits, and our rehab strategies. There is, you know, the World Health Organization has clinical management of COVID, including, you know, rehab and long COVID, and that's what you see on the right. But kind of the questions we need to start asking is like, how is this adapted to an individual with substance use disorder? And so the medical community can better train health professionals on how to treat these patients. And that begins with ensuring that clinicians approach these disorders as something that's treatable, chronic health conditions, and use appropriate language. So kind of we have to teach individuals about substance use disorder, and we have to, you know, also teach clinicians about long COVID and understanding that these are like chronic, treatable, or manageable medical conditions. So one thing when we really consider, probably in one study for long COVID patients, 25% of the symptoms are sometimes pain related. So if someone's pain symptoms and they may have, you know, a history of substance use disorder and opioid use disorder, then we have to, you know, consider in these patients that have um, pain, then, you know, clinicians in this case, they are faced with two significant challenges. You want to manage pain, but you want to minimize morbidity and mortality associated with opioid misuse and abuse. And so, you know, increasing numbers of patients that have pain and opioid use disorders, and we have to be cognizant kind of the comorbidities. So again, these patients, they need to be screened. They need to be screened for withdrawal, screened for suicide risk. We have to do a physical exam to make sure any comorbidities are treated. And the best practice is going to be like a medication for opioid use disorder, cognitive behavioral support, counseling, and then non-pharmacologic approaches as well. One thing I think is kind of interesting to bring up is low-dose naltrexone, because I know naltrexone's used sometimes in substance use disorder treatment, and low-dose naltrexone is now being used as a novel anti-inflammatory agent in the central nervous system because it acts on microglial cells. And so this is something that's really unique to the low dose. Like the standard dose is 50 to 100, but in my patients, I'm using like 1.5, 3, something like that. And so it's a little bit, it's very much independent from naltrexone's better known use on opioid receptors, but really kind of working on that toll-like receptor 4 that helps it be kind of more anti-inflammatory, and it has been used before in neurologic conditions as well. So we're now starting to use it in long COVID. This is a study that also came out of Stanford's long COVID clinic. And really kind of the big things, it was helping with functional status, fatigue, post-exertional malaise, unrefreshing sleep, and abnormal sleep patterns. So really, you know, good positivities. This is just in the last, you know, minutes before the, you know, we answer questions, is really, we need to do integrated care approaches. So this is kind of our mission statement from our long COVID clinic that again opened in 2020, where we want to, you know, serve our patients and give them, you know, compassion and professional care. This is now being expanded with an AHRQ grant to try to make it a little bit more multidisciplinary what we use. So this is, you know, what is part of a perfect multidisciplinary team works with like primary care, physical medicine and rehab, specialists as needed, having cognitive behavioral support, psychology, physical and occupational therapy, having social work and case management, and peer and community support, and everything else that you see on the right side. You know, we talked about comprehensive assessments, individualized treatment plans, holistic health promotion, and continuing to do this work at the community level. So I will say thank you, and we'll happy to stop share and look at the questions.
Thank you. Thank you, Dr. Verduzco. And I don't know if our participants can see me now. Okay. Can they see me now, Rafael? Okay, all right. Thank you, Dr. Verduzco. Great presentation. We already have some questions here in the chat for you. And there was one specifically to low dose naltrexone. I know you addressed that during the presentation, but just wanted to bring it up again. It says, would there be any contraindication in low dose naltrexone use, as doses are much lower than typically used? And we're talking specifically about substance use disorders.
Yeah, so if I have a patient who is on opioids, then I, don't put them on low dose naltrexone. So it's only ones who, I have to look at their PMP. We have to discuss what other medications they're using. So that would be a limitation to low dose naltrexone. Or if they're going to be, I mean, like I said, sometimes drinking alcohol makes them feel really bad, period. So, and like I said, the dose is really, really low. So if they're still having a little bit of alcohol now and then, that's usually not something that I will, tell them don't have any, or you'll feel bad because it's kind of a low dose.
Thank you. Then we have here says, is there any studies about children who have had COVID and internal organs damaging more easily? Is there a correlation there?
So there are some patients, some children who get the multi-system inflammatory disease after COVID. And then also they've seen like increase in some autoimmune diseases, both type 1 diabetes with children and also type 2 diabetes in children and adults actually. And so there's still a risk in kids. It may not be as high as a risk as it is in like I talk about middle-aged females, but there are kids that get long COVID for sure.
Thank you. We have another question here. Oh, good point. Is low COVID somewhat it can be resolved? Like definitely, can we get rid completely of long COVID? Meaning the person who already had long COVID, is there a point of time when they stop experiencing the symptoms?
So I think there are, if you look at kind of the different studies that look at over time, is that there's patients that, like I said, there's percentage, it said like if, 18% of the population had long COVID, but only currently experiencing long COVID are 6.8% of patients, then there are patients who are getting better. And sometimes it's just, do they have a better immune system? Their immune system snapped out of it. They just had the other thing like lesser symptom burden. Did they have a milder case? We know that patients who got COVID earlier in the pandemic and had long COVID, it's kind of they have more symptom burden than ones who maybe got some of the more recent variants, being able to get over long COVID. And so I think it just depends on your risk factors, what your body does that we don't even know yet, what type of COVID you had initially, type of thing. So some people get better. We just need to
Okay.
find out how and why. And then we don't
Okay.
have yet like a magic pill to be like, oh, and this.
Of
Yeah.
course, of course.
Yeah.
And then I have another question here. And this is just for me personally. How do you think that behavioral health professionals, which we have many here in our participants, among our participants, how do you think they should address talking about COVID? Should that bring up as part of their interaction with their patients or clients? When they're supporting them and ask them if they have had COVID in the past, or should they wait for the patient to bring it up? It's just general question, considering their own behavioral health and they establish those interactions with them.
Um, the way I describe COVID, I sometimes think it's like it's igniter fluid. So if someone gets COVID, that if they have something that's underlying, it can, the inflammation induced by COVID can make it worse. So sometimes I think it's an important part of a history. Are they having like a flare of their, underlying psychiatric disease? Are they having, something like more fatigue? Are they sleeping worse? I just still like to get that part of the history to say, like, is there something that is triggering it? Is there something, and this could be one of those things that might be contributing to these changes that are happening. Yeah.
Mhm. Thank you. And I think I have, is there another question here? Someone here is adding to our chat. In dealing with post-COVID pain, how far down the way are opioids used?
I will say that I probably have been prescribed in, you know, I don't know, 3.5 years of having a long COVID clinic. I'm not prescribing opioids. I feel like a lot of times you have to find the right, like, if someone's having pain, then what are other, what can be treated? Not all pain needs to go straight to opioids. The other thing is sometimes the pain is paresthesias, small fiber neuropathy. Small fiber neuropathies should not need to be treated neurologically. Do they have an underlying autoimmune disease that's driving their small fiber neuropathy? Then I'd rather treat them with autoimmune medications or IVIG than giving them an opioid or giving them like gabapentin or some other medication for nerve pain, not an opioid. So, and if patients have migraines, opioids are very inappropriate for migraines and can cause, and because there's a lot of migraines after COVID and can actually cause worsening migraines. So again, I'm not going to use that class of medications that don't properly treat the underlying pain.
I see. And I think it's going to be your last question, probably, but it's kind of a follow-up about what we're talking about. What are the most common symptoms that remain for a long time after a diagnosis of COVID?
Yeah, so I think it just kind of if you've seen one patient with long COVID, you've seen one patient with long COVID, but I think some of the fatigue, some of the post-COVID cognitive deficits, and the post-exertional malaise, that specifically being that someone may do an activity that seems simple, but afterwards they actually crash or have worsening of their symptoms after doing something that they can previously do before. That's probably one of the biggest hallmarks of long COVID. So, yeah.
I'm not sure if we still have more time for questions or if we should go to our announcements. Let me see what my team tells me here in the chat. Yeah, I think it looks like we can go to our announcements, and just wanted to remind all of you, if you want to receive your CME credits, what you have to do is text today before midnight, attend 100-95595 to the number that you see on the screen. Please make sure that you send this code today before midnight. Please write it down if you cannot do it right now. And to claim your CEUs, as I said at the beginning, you will receiving a post-session survey after this class. And once you answer it, please give it 2 or 3 weeks for us to send your certificate via email. So it's that easy. If you have any questions, you can always contact us here at Be Well Texas, at utesca.edu, and we'll be more than happy to help you obtain your certificates. Next. And in this same 8-part webinars, our 4th session is going to be so interesting. It's Dr. Brittany Houston talking about recognizing COVID-19 related compassion fatigue and enhancing provider resiliency. Another very important topic related to COVID-19 and substance use disorders. Please don't miss it. That is Wednesday, April 17. If you want to keep registering for these sessions, remember, go to cstat.utesca.edu/COVID-19 webinar. You can register for all our coming sessions there. You guys are doing great or attending our sessions. I know there's a lot of much more interesting information to share with you. Just go and register, and we'll see you Wednesday, April the 17th. And to all of you, Dr. Verduzco, once again, thank you again for a great presentation. If there are other questions or comments on the chat, we'll try to address those after the class. Thank you to all of you, and we'll see you in our next session during this webinar. Thank you again. Have a great rest of your day. Thank you.